Up next, Steven Nissen is joined by Dr. Marie-Claude Morice, Director of Interventional Cardiology at the Institut Hospital Jacques Cartier in Marseille, France. They cover diabetes and coronary artery disease. Is PCI still an option?
First, let's talk about what the evidence shows to date. So perhaps you could talk about the key trials that compared Cabbage and PCI, and then why you think that they may not be applicable to everybody.
No, it's absolutely true that first the topic extremely important because you know that diabetic population is increasing and at high risk. And it's true also that the evidence that we have now is in favor of surgery in the diabetic patient, thanks to two major trials. First, the diabetic subgroup of Syntax, which showed clearly superiority of surgery versus PCI, and even more the Freedom trial dedicated to diabetics, where there was very clear difference in favor of surgery, even in terms of mortality. So the evidence is against PCI.
In Syntax, what were the endpoints that drove that result?
In Syntax, it was less clear. There was no difference in mortality, but more MI and more target lesion revascularization, much more revascularization.
Could you maybe give our listeners an idea of how big those differences were? Were they small or were they large?
No, they were large. And in terms of MACE, there was more than 12% absolute difference. It was really, really important. But it must be noted that diabetes is a risk factor for both revascularization. Surgery has also worse results in diabetes than in non-diabetes, but it was clearly better than PCI in this population.
And in the Freedom trial, the mortality difference, how large was it?
I'm sorry, I don't have my slide there.
It's okay, but it was not a trivial difference.
Not a trivial, and it was very significant.
It was significant.
No, it was significant. There is no doubt that within this trial, surgery was the recommendation.
Now, in your view, what are the limitations of those studies and why might we want to revisit this issue?
Yes, it's absolutely true that we need to revisit because those two trials were using stents that are not anymore in the shelves of any part of the world. And it's absolutely true also that the second and third generation of DES prove to be clearly superior to those stents, mostly in terms of safety.
Now, you know, this is not a new argument. We talked about this earlier, that whenever there is an outcome with intervention that is less favorable, the argument's always made, well, that was the old generation, you know, with balloon angioplasty, and then stents
BARI,
came along, and then drug-eluting stents came along. And so, you know, we always hear the argument that, well, they just used the wrong technology. And so I'd like to understand how much better are these new generation stents in diabetic patients. Do we know that?
Yes. When you pull, for example, all the results of the SPIRIT trial with the Xience versus Taxus or even versus Cypher, which is a little better, there is a clear difference. As I told you, mainly there is less TLR, but it's not the most important. The most important is there is clearly much less stent thrombosis. The late stent thrombosis even disappear with this generation of stent. So less MI and, of course, less sudden death.
Could you maybe help us understand the magnitude of these differences? So in the pooled analyses, how much better are these newer stents?
I don't have the numbers in front of me. It's very significantly different, both in terms of MI. If I remember well, in the pool is from less than 1% with the new generation, 0.8, something like that, to 7, near 3. So it's
big.
Very big.
It's more than double.
Yes, much more than double. Yeah.
Now, surgery, of course, also makes progress too. Is there reason to believe that surgery has gotten better over the years?
I do think they are making progress because I know well the Syntax trial. If all patients receive one mammary, very few of them receive 2 mammaries, for example. It was around 20%, so not big numbers. And less than 20% have complete arterial revascularization, meaning that it was not, and there was near no upcap surgery. So it's true that since that period, surgeons have improved, but I'm not sure it has the same magnitude as the evolution of PCI.
From your perspective, in terms of patient selection for Cabbage versus PCI, what are the critical factors that you use in making that decision?
Of course, you have to take into account the patient risk, meaning the STS score, Euro score, because it counts a lot for surgery. And for PCI, it's mostly diffusion of lesion. For example, a left main in its side, it's not an issue for PCI. It's not a contraindication, clearly. But it's diffusion of the disease. The more diffuse, the better surgery result.
And what about, we see sometimes patients with these very distal lesions. Does that have a big impact on your thinking?
Yes, because we know that mammary works well even when there is a poor distal bed, which is probably not the case of PCI. So it's also an argument in favor of surgery in those patients.
What about age? You know, we see in more and more patients in the U.S. that are much older with coronary disease than we did years ago. Is that a factor in your decision-making?
Yes, of course, when they are very old, we favor PCI. But there is a new argument, which are, for example, we have much better antiplatelet treatment than at the moment of freedom where it was only clopidogrel use. Yes. We know that the new agents are more potent, in particular in diabetic patients, which are often resistant to antiplatelet. So this has been to be taken into account, also going in the PCI. And for me, a big hope is also that maybe I'm too optimistic, but we see that there is a more active and better, there is new insulins that are coming to better control diabetes. So I hope that in the next few years, they will become as less risk as they used to be.
How does gender factor into your decision-making about Cabbage versus PCI?
Gender doesn't make the difference. There is some data saying that outcomes are worse with women in surgery, but they are not very strong. When you look to the data of the big, for example, in freedom, in syntax, there was no gender difference.
Any other factors that you routinely consider in making that decision on surgery versus PCI?
No, honestly, the surgical risk assessed by STS that we use and diffusion of disease by syntax score. And also, I think the fact that now we have available FFR, we use it a lot because sometimes you think that there is a lesion to treat. And if FFR is negative, it's much better not to treat it. That's also a new data that we have that help us in decision making.
Well, thank you so much for enlightening our listeners about this very interesting and controversial topic.
Thank you.